Good morning. The first item of business is a debate on motion number 956 in the name of Murdo Fraser on cancer drugs and their availability in Scotland. Members who wish to take part in the debate should press the request to speak button now, and I call on Murdo Fraser to speak to move the motion. Mr Fraser, you've got 10 minutes.
Thank you, Presiding Officer. We have all seen the newspaper headlines. Scots worst for cancer survival. Lung cancer survival amongst the lowest in Europe. Scotland has the lowest breast cancer survival rate. And the sad truth is that report after report tells us that Scotland lags behind a plethora of other developed countries in survival rates for cancer. Norway, Sweden, the US, Canada and France are just a few examples of countries which boast of better 5-year survival rates across a range of cancers than we do here in Scotland. Now, I accept there has been some improvement in the figures here in recent years, but I want to highlight today a more serious problem, and that is that we Scots also lag behind a significant proportion of Europe for access to new cancer medicines, even though successive price cuts and exchange rate movements have meant that UK prices are currently amongst the lowest in Europe. It's our job as parliamentarians, as compassionate members of society, to ensure that when someone is diagnosed with a terrible illness like cancer, they have the best possible fighting chance of beating it, or in the most extreme cases, can at least extend the time they can spend with loved ones for as long as possible. In June this year, one of my constituents, Gillian Bold from Dunblane, sadly died after being diagnosed with advanced metastatic breast cancer. Her husband had contacted me prior to her death to raise concerns about the difficulty his wife was having accessing lapatinib, a drug not approved by the SMC, but one which presented the best way of controlling the disease's progression after her chemotherapy came to an end. The Bolds made 2 separate exceptional prescribing requests by 2 different consultants and were rejected both times. Because this drug was not approved by the SMC and because the exceptional prescribing route had been closed down to them, Gillian's consultant advised the only option left open to the family was to pay for the treatment themselves, at a cost for a 12-week course of £10,000. And that was unaffordable to that family, as it would be to many other families across Scotland, and it really was a crushing blow at what was already a very difficult and distressing time for the family. And the really devastating fact for Gillian was that had she been living in England, she would have met the specific criteria laid down for access to lapatinib through the Cancer Drugs Fund. As her husband wrote in a letter to the Scotsman, "The interim Cancer Drug Fund is intended to help people like my wife. If we lived in England, then she would fully meet the criteria for funding, whereas in Scotland she isn't considered worthy of further help." Presiding Officer, I'm sure there are many cases all across Scotland, like my constituent Gillian Bold, and I'm sure there are members here today who have dealt with or are currently dealing with such similar cases. According to a report published by the Rarer Cancer Foundation, there are now 23 cancer treatments which are not routinely available in Scotland, but which could be funded through the Cancer Drugs Fund set up by the Conservative-led coalition in England. Now, I know the Cabinet Secretary will dispute the figure of 23 cancer drugs. I've read the correspondence she has sent to my colleague David McCletchie, and I've also seen the vigorous rebuttal to that from the Rarer Cancer Foundation, which was sent to the Health Services Research Unit on the 8th of September. And I'm not here today to get into a dispute as to whether the figure is 23 or some lower figure. I would simply acknowledge the Cabinet Secretary believes it is not 23, it may be as low as 12. It seems to me that isn't really the point, Presiding Officer. Even the Cabinet Secretary will accept there are cancer medicines available in England which are not available in Scotland. And even if we can't agree on the number, the principle is still established. The Cancer Drugs Fund totals £600 million over 3 years, in addition to an initial £50 million. And it has helped 5,000 patients in England to get access to the cancer medicines they need. And it is facts like these, Presiding Officer, which convince me that the Rarer Cancers Foundation are right when they argue that around 14 treatment requests per million population are being approved in Scotland, compared to almost 48 such requests in England. Indeed, lapatinib, the drug my constituent required for her breast cancer, has an approval rating 9 times greater in England than it does in Scotland. In fact, if Scotland were to set up its own fund and achieve the same approval rate as England, across a whole host of drugs, there would be a 235% increase in the number of cancer patients in Scotland gaining access to life-enhancing and life-extending treatment. And I think we need to remember here we are dealing with many, many people who are reaching the end of their lives. These drugs very often are not about saving their lives, they are about prolonging them and giving them a better quality of life in a situation where they need that extra help. Now, I acknowledge this fund is an interim measure. It is proposed as such south of the border and would also be an interim measure in Scotland. It will run until 2014, when the Department of Health are intending to replace the current pharmaceutical price regulatory system with a value-based pricing system for drugs. That's a system I hope the Cabinet Secretary will be supporting here in Scotland. And this change will link the price of a drug to cost-effectiveness based on clinical evidence. It is hoped that the new system will lead to more innovation and investment being focused on patient needs. However, until that time, I do not believe we can morally accept a system whereby Scottish patients are being denied access to cancer drugs which are available to other UK citizens simply because of where they are domiciled. Now, of course, the Cabinet Secretary will, I'm sure, when she gets to her feet, extol the virtues of the individual patient treatment requests arrangements, which is the default position of the Scottish Government when they are challenged on the issue of availability of cancer medicines. But the fact remains that even with this system, as my constituent Gillian Bold found out, access to cancer drugs is still being denied, vital drugs which are being made available in England. The Divided Nations report from the Rarer Cancers Foundation highlights that in the group of medicines that are declined by the SMC patients, patients do not access them through the IPTR route. And that is why patients in Scotland are 3 times less likely to gain access to a cancer drug not routinely available than those in England. As one clinician has told me, bevacizumab, I hope that's pronounced correctly, is a very good example of such a medicine. This drug has no SMC approval and no successful IPTR appeals, despite this drug being the gold standard of treatment of advanced colorectal cancer in the Western world, and now in England, with the introduction of the Cancer Drugs Fund. So again, Presiding Officer, it is being made available to patients in England and Wales, but not patients in Scotland. Cancer Research UK welcomed the English Drugs Fund, saying this Cancer Drugs Fund could make a real difference for some cancer patients, allowing them to get the treatments they need. I know there are other cancer charities that take a different view, and it's clear there is a divided opinion, but undoubtedly there are patients in England who are benefiting from this, which is why cancer sufferers and many clinicians and many experts can see the evidence of the £600 million Cancer Drugs Fund working for cancer patients in England. The Rarer Cancer Foundation has estimated that the cost of achieving a comparable level of access in Scotland would cost the Scottish Government £5 million. In the context of the health budget, that is an insignificant amount. Indeed, in our manifesto for the Scottish elections earlier this year, we identified where that money could be found from. We believe it would be money well spent. Presiding Officer, I do not believe, and we do not believe, that cancer sufferers in Scotland should be treated any less well than those elsewhere in the United Kingdom. I believe it is time for the Scottish Government to think again on this issue, and I have pleasure in moving the motion in my name.
I now call on Nicola Sturgeon to speak to and move amendment number 956.2. Ms Sturgeon, you've got 7 minutes.
Presiding Officer, let me begin by saying that I welcome this debate. I think all of us in this chamber recognise that these issues are complex, they're emotive, sensitive and often very challenging. But I think that puts an obligation on all of us to debate these issues rationally, responsibly and accurately at all times. I want to start with this issue of comparisons between Scotland and England. These comparisons are not always valid, and often, Presiding Officer, they are extremely misleading. The simple fact is, lists of medicines do not tell the whole story of improvements in cancer care. It is not as simple as saying that at any one time there is a single fixed list of cancer medicines being provided in England but not in Scotland. I have seen and studied the report of the Rarer Cancers Foundation. It is helpful in many respects, and I respect the work that that organisation does. But the fact is, it contains errors. Some of the claims that have been made in it, the basis on which the conclusions have been reached, are open to serious challenge. For example, some of the medicines listed as not available in Scotland are available in Scotland. There has been double counting. Some of the not recommended decisions are not recommended because the pharmaceutical company in question had not made a submission to the SMC. I'll be discussing these issues in due course with the Rarer Cancers Foundation. The fact is there are, and there will continue to be, differences between Scotland and England. There are drugs available in Scotland that are not available in England. The position changes rapidly because of the number of new medicines that become available. And of course, we should always remember that while NICE in England reviews a selection of new drugs, the Scottish Medicines Consortium quickly reviews all new drugs that get a licence. And of course, making these comparisons suggests that there is a uniform position across England. That's not the case. From what we can see from the published policies on the Cancer Drugs Fund, different regions in England are adopting different approaches to the application of that fund. The key point here that I want to make today is that the Scottish Government has been anything but complacent on this issue. We've worked collaboratively to put in place continuously improving, robust arrangements for the assessment and introduction of new medicines. That was demonstrated in the substantial amount of work done in conjunction with the Petitions Committee, and it's instructive to note that in closing that petition, the committee highlighted the improvements that have been made in the NHS in Scotland. I've said previously, and I will say again today, and I will continue to say, that I am and always will be open-minded to what more can be done, and I will always consider any ways in which we can further improve access to clinically and cost-effective medicines that improve outcomes for patients. So we're keeping the existing arrangements under review, and we will make changes where necessary. We're also looking to the future. The position continues to involve with, for example, the UK Government plans to introduce value-based pricing. I've written to the Secretary of State for Health. We're working with the Department of Health in England to ensure that our interests are fully recognised so that we can consider the wider implications for Scotland. But fundamentally, our efforts remain focused on these three principles. Firstly, robust and independent national and local arrangements for the timely assessment of new medicines to ensure they are both clinically and cost-effective. Secondly, consistent arrangements for consideration of individual cases where a particular medicine is not recommended by the SMC, and the vast majority of these individual treatment requests are granted. And thirdly, a clear focus on equity. And while I do absolutely understand the prominence given to cancer drugs, and I can see the attraction at first glance of a cancer drugs fund, it is that concern about equity that leads me to agree with Breakthrough Breast Cancer, Macmillan Cancer Support and Myeloma UK in a briefing for this debate, a briefing that recognises and welcomes the extent of the improvements that have been made and recognises the need for these to bed in. These respected cancer charities have said that, in their opinion, a cancer drugs fund is not a necessary policy for Scotland. And for my part, there are two key equity concerns. Firstly, the risk that a cancer drugs fund will create inequity between those suffering from cancer and those suffering from other serious conditions like Alzheimer's or heart disease. We should continue to improve access to drugs, but in my view, that should be access to all drugs, not just cancer drugs. The second, briefly, yes.
Murdo Fraser.
For the Cabinet Secretary for giving way on that point, I understand entirely the point she's making about equity, but surely at the heart of this question of equity is the fact we are where we are in relation to decisions taken by the Department of Health in England and Wales, which means that there are patients today in England and Wales getting access to cancer drugs not available in Scotland. Surely in the interest of equity, that is the question that needs to be addressed.
Cabinet Secretary.
I've already challenged that proposition, and I'm happy to do so in greater detail in discussion with Murdo Fraser. But the second key issue of equity is the risk of inequity within cancer care. You know, drugs are an important part of the battle against cancer. They're an important weapon in that battle, but they're not the only one. Radiotherapy and surgery are increasingly the treatments of choice. We need to invest in them too, and we need to do more to prevent cancer in the first place. Murdo Fraser quoted Cancer Research UK. He didn't quote this opinion from Cancer Research UK. The Cancer Drugs Fund has been criticised for funding non-cost-effective chemotherapy treatments rather than other, possibly more effective interventions, such as drives for earlier diagnosis or more advanced radiotherapy. I think that's a key fundamental point, and it's that broader, more comprehensive approach that has seen us investing £22 million in new radiotherapy equipment. And it's for these reasons that we are committed to improving cancer survival rates through the earlier detection of cancer. That Detect Cancer Early plan is backed by investment of £30 million. So, in short, Presiding Officer, we are committed to and will continue to be committed to tackling cancer on all fronts. And we are seeing major improvements in the quality of care and outcomes for cancer patients. We will continue to prioritise further improvements through a consistent, evidence-based approach to the introduction of new medicines, treatments and support, alongside that crucial commitment to detect cancer early. And of course, in looking to the future, we will ensure that our interests are fully represented in the development of value-based pricing arrangements. I look forward to this debate this morning, Presiding Officer, but in the meantime I move the amendment in my name.
I now call on Alison McInnes to speak to move amendment numbers 956.1. Ms McInnes, you've got 4 minutes.
Thank you, Presiding Officer. Back in 2009, in response to the Public Petitions Committee inquiry, the Cabinet Secretary outlined 3 steps her government would take to improve access to medicines on the NHS, and we welcomed that approach. She said at the end of that debate, my objective is to ensure that we have a system in place that is from end to end robust, fair and well understood, and that such a system should ensure that when a patient can derive demonstrable benefit from a drug, it's available in the NHS, either through SMC approval or exceptional prescribing. The situation, as Murdo Fraser has outlined today in Scotland, is that they're 3 times less likely than patients in England to gain access to a cancer medicine that's not routinely available. And there are geographical variations in the rate of exceptional case applications, as well as variations in a patient's chance of making a successful application. And that variation is not acceptable. Relying on the exceptional cases process can, of course, also be stressful and time-consuming. The Rarer Cancer Foundation report, The Scottish Exception, found that an increasing number of Scots are having to rely on exceptional case applications, that nearly a third of NHS boards have no written policy governing exceptional case applications, and that NHS boards use variable criteria to assess these exceptional case applications. It's clear, therefore, that more work is needed to ensure that there is a transparent system in place that is from end to end robust, fair and well understood. Expenditure on drugs amounts to almost 10% of the NHS budget in Scotland, and I understand that this is an area in which tough decisions will always need to be made. Weighing up effectiveness against resources is an extremely difficult task and must be done in a rigorous and scrupulously objective way. It may well be that the criteria which are used to make those decisions need to be examined to see whether they disadvantage drugs designed to treat rare diseases. However, the Scottish Liberal Democrats do not agree with the argument that we should bypass the Scottish Medicines Consortium for cancer drugs. This is, I think, intellectually unsound, it's unsustainable and it's unfair for those suffering from other conditions. And politicians shouldn't be second-guessing the SMC. Like Macmillan Cancer, Breakthrough Breast Cancer and Myeloma UK, we do not support the creation of a separate cancer drugs fund. The SMC's role is to make objective decisions about individual drugs, and recent initiatives should be given a chance to demonstrate their efficacy. Cancer Research UK has admitted that the bigger prize is in achieving a decent settlement in negotiations over value-based pricing, and I would urge the Scottish Government to engage with the UK Government to ensure that the new scheme meets the needs of patients in Scotland. The evidence we've seen is that record-keeping in NHS boards is still poor. Nearly 2/3 of the NHS boards do not hold information on the costs associated with funding exceptional case applications, and I'd like to see that change. To help move the debate forward, the Government must increase transparency throughout the system, and it perhaps should consider commissioning research into which factors contribute to situations where drugs are deemed to be safe and effective, but not cost and clinically effective. One of the steps the Cabinet Secretary outlined in 2009 was a set of modifiers that the SMC can apply when considering new medicines. Can she tell the Chamber if any assessment has been made as to the impact that this more flexible approach is having on access? And have any drugs been approved due to these modifiers, which would not have been approved under the standard methodology? We should be seeking a much greater contribution from the pharmaceutical industry in this matter, and they should be working with the Scottish Government to encourage patient access schemes and risk-sharing approaches. Our manifesto focused on improving early detection rates in order to increase survival and set out plans for a new target of urgent referral for cancer diagnosis. We think every patient should expect to see a specialist within 2 weeks. We must focus on increasing early detection to tackle the unacceptably high number of cancer cases that are only detected for the first time during emergency admission to hospital. Presiding Officer, this is an emotive subject, but one which really benefits from the calm and impartial consideration that the SMC can bring. I move my amendment.
I now call on Jackie Bailey. Ms Bailey, you've got 4 minutes.
Can I join in thanking the Conservatives for bringing a debate on access to cancer drugs to the Chamber, because it does give us all the opportunity to consider how well or otherwise the system is working in Scotland and what changes might be necessary. But can I say at the outset that we do not support the development of a cancer drugs fund in Scotland. We know that treatment is changing. More and more cancer patients are diagnosed early, and surgical intervention and radiotherapy are increasing in use. So we believe that the real prize is actually to invest in early diagnosis, early treatment, because we know it leads to better outcomes for patients. But our lack of support for a cancer drugs fund doesn't mean that we believe that the current system is functioning as well as we would all wish it to do. Recent changes made by the Scottish Government following a petition to the Parliament are very welcome indeed. They have made substantial improvements to the system, introduced a process whereby a clinician can initiate an individual patient treatment request. But let's look at some of that in a little more detail. Now, we are all aware of the role of the Scottish Medicines Consortium making the decision about which drugs are licensed for use based on clinical and cost effectiveness. But we then have 14 separate area drug therapeutic committees, one for each health board. Given that the same guidance applies across all health boards, it's difficult for us to understand why different NHS boards take such different lengths of time to decide on cancer drug use. And let me illustrate that with one example. A cancer drug deemed OK by the SMC to use in April 2009 was agreed by 2 out of the 14 health boards within a month, but it took a further 16 months before that same drug was agreed for use across Scotland. So we do still have a postcode lottery. The second issue that I want to raise concerns the individual patient treatment request, an innovation to improve our existing system, which we absolutely approve of. It does enable clinicians to make judgments in the interests of their patients, and it was supposed to be our equivalent to the Cancer Drugs Fund in England. The process should, when it's working effectively, support clinicians to make the medicine available to those who will benefit most, regardless of cost. But there is a growing body of anecdotal evidence that the process is being undermined by, firstly, local rules that prevent the initiation of the individual patient treatment request, secondly, routine rejection of requests, thirdly, a refusal to even consider requests in the first place, and lastly, the very quite considerable administrative burden that's placed on clinicians, posing an added difficulty to getting into the system. So it's hard to determine, frankly, whether that perception is correct, as the Scottish Government currently has no mechanism that I'm aware of to compare the number of requests and approvals. Now, we all want to see this working, so can I encourage the Government to consider indeed?
It's a point of information more than a question. Jackie Bailey will be aware, and if she's not, she will be now, that as part of the improvements through the Petitions Committee, we are gathering the data on a request made and approval so that we can compare across the country what the position is.
That would indeed be helpful, and I hope that we can gain access to that soon, because I am going to encourage the Scottish Government to make further improvements. I pose the question, do we need 14 area drug committees? Perhaps we do, but they seem to be acting as a blockage in the system, duplicating the work of the SMC and delaying availability of drugs. And if we are monitoring and collecting data, can we apply that to ensure that at every health board, the individual patient treatment system is indeed working effectively? We value the work being done on value-based pricing of medicine. We support any approach that leads to early detection and treatment of cancer, but it is not something that we should be proud of, that there are fewer cancer patients in Scotland, perhaps 3 times less than in England, having access to treatments. We need to make a difference and ensure our existing system enables access to cancer drugs.
We now move to the open debate. Can I remind members that your speeches should be 4 minutes. Time is really tight. I call Dennis Robertson to be followed by Malcolm Chisholm.
Thank you, Presiding Officer. This is a very emotive debate, and can I say that I thank Breakthrough Cancer, Macmillan Support and Myeloma UK for the briefing that we had. Some phrases have already been used within this debate, and Murdo Fraser used the word morality with reference to the setting up of the fund, or not having the fund within Scotland. I think my challenge to Murdo would be that I would think it slightly immoral to challenge the competency of the MSC in terms of the work that they're doing. I would also say in terms of fairness and equity, which the Cabinet Secretary mentioned, that I believe that it wouldn't be too long before other groups would be coming back to this Parliament and making submissions that they didn't have a particular fund as well. And I would refer to areas like diabetes, stroke and heart, asthma and chronic bronchitis, etc. It is worthy, obviously, to look at ensuring that we have early prevention. And I think the work that the Government has already done in providing £30 million in early detection prevention is a route into ensuring that patients are given the best possible care at the best possible time. I respect the work of clinicians and their judgment, and I approve of virtually all the points made by Jackie Bailey in terms of the work that's moving forward. But I would say in terms of the clinicians, it is up to them, and if they feel that their patient warrants a particular drug, and they do have the mechanism to go forward with that independent request for that drug. And I welcome the comments by the Cabinet Secretary to say that this is now being monitored and there's a measurement in place, so we should get that evidence eventually. I would say that with reference to the fund, England is the only country that is moving forward in the devolved countries. Wales doesn't seem to be moving forward with this. Northern Ireland have no intention of, and I believe in Scotland there is no need for it. Presiding Officer, this debate will probably raise many issues, but can I go back to just the equality one in my last few comments? I believe that every person who has an illness in Scotland requires the best possible treatment at any given time. And to ensure that that happens, we cannot set up individual funds for specific conditions. Thank you.
I now call Malcolm Chisholm to be followed by Alec Johnson.
Presiding Officer, I very much welcome this debate, which highlights dilemmas that we face now, dilemmas which will in fact become far more acute in the near future. At a recent visit to the Edinburgh Cancer Centre and the labs there, I heard David Cameron, the very highly regarded David Cameron, who is the new Professor of Oncology at Edinburgh University, describe how new cancer treatments are targeting specific subtypes of cancer, and that therefore the cancer drugs that are already expensive are likely to become far more expensive in the future, as they will be used on smaller subgroups of patients rather than everybody, for example, who has a particular type of tumour. So he was highlighting there what difficult choices we were going to have as the drugs budget increases exponentially in the next decade. I think the second general point I would make, which the Cabinet Secretary made, is that drugs are not the only weapon against cancer. And I think, again, in a recent talk, Professor Alan Rodger, who was the director of the Beatson Oncology Centre until quite recently, gave figures which said that the contribution of different treatments to the cure of cancer was surgery 68%, radiotherapy 28%, chemotherapy 4%. Now, that is not in any way to downgrade or devalue the role of chemotherapy, but I think we do need to see cancer treatment in that broader context. Now, I think we should justifiably be proud of the Scottish Medicines Consortium, and I think that is the foundation of of our system in terms of cancer drugs. And I remind members of what the Director of Cancer Research UK said at the Petitions Committee on the 29th of April 2008. He said the SMC is the envy of clinicians who work in England. It is a model of good practice. So I think we should be justifiably proud without being complacent about it. I seem to remember that guidance was issued in relation to the Scottish Medicine Consortium some years ago, which states that NHS boards should ensure that recommended medicines are, and I think I quote, available to meet clinical needs. So I am concerned that there still seem to be some issues about the implementations of SMC decisions by boards. And both the Cancer Research UK briefing we received and the one from Breakthrough Breast Cancer, Macmillan Cancer Support and Myeloma UK highlight the need to have more transparency, not just around the decisions themselves, but also about the implementation of those decisions by boards. So I'm sure that is something that everybody would like to see. But the briefing by Breakthrough and others also makes the key point that they want recent initiatives to have a chance to bed in. And I think the Cabinet Secretary should certainly be commended on the announcements that she made in 2009 around exceptional prescribing becoming more transparent. She talked about greater transparency and the flexibility that can be used by the SMC, and a national framework for assessing patient access schemes. So I think that was all good. I suppose the only point I would make, and she probably won't have enough time in her summing up speech, I think it would be good in the interest of transparency if the developments of those policies could be explained to MSPs and the wider public. For example, I'm told that guidance on exceptional prescribing was issued in March 2011, but it may be that most people don't really know the contents of that or how it's operating. So I think if people had more confidence around exceptional prescribing, there might be less demand for the Drugs Fund. I do sympathise with what Murdo Fraser says in many ways, and I can see exactly where he's coming from on this. But I think we should remember, as Cancer Research UK reminds us, that the Cancer Drugs Fund could actually exacerbate regional inequalities and may well be doing that in England. So it may be that guidance around exceptional prescribing is a more equitable way to deal with this problem.
I now call Alec Johnson to be followed by George Adam.
Thank you very much, Presiding Officer. For a country that is reputedly obsessed with sport, Scotland's health record is not good, and we all know it. Much of the time that this Parliament has existed, its key effort has been to improve Scotland's health. And of course, our record in heart disease and cancer exemplifies the problems that we face. And of course, we know it's caused by industrial reasons, and we've seen the improvements in smoking and alcohol, and we're trying to work on the alcohol issue. But that good work that has been done proves that success is possible. The problem we have now is that statistics appear to exist that indicate that here in Scotland you are less likely to survive a cancer, you are less likely to have a prolonged life than you are in much of North America or comparable countries in Europe.
Cabinet Secretary.
And it's that key concern that I wish to address today, and I won't take an intervention because I've only 4 minutes and I need to get one key principle across. Now, I visited a research unit at Dundee University some years ago and spoke to a senior researcher who looked into the future and suggested to me that he could see a time in the future when there would be a cure for every cancer. The problem was that every cancer would have an individual cure, and that he himself could see the economic problems that there would be in funding such a health provision. But we all know that new medicines are becoming available, and that there are individual cases, such as the one highlighted very eloquently by my colleague Murdo Fraser today, where individuals believe that a particular drug treatment would be effective in their case, but cannot have it funded through the Scottish system, but while they would have it funded through the system currently available in England. Now, there's a principle here, and a principle that must lie at the very heart of our National Health Service. The National Health Service must provide for everyone and must be seen to do so. But we have had an opposite argument put here today, and I'll explain why I believe that's an opposite argument. When the Minister and others, including Jackie Baillie, talk about the principle of equity and how we need to ensure that resources is issued or allocated equally across the board, That is a fundamental principle of collectivisation, in my view. And when we hear major organisations who have submitted briefings for this debate today saying that there is no need for a cancer drugs fund in Scotland, then I would suggest that that collectivisation of opinion is not benefiting us in this argument. There is a fundamental principle that lies at the heart of my political point of view that says that the rights of the few must at times outweigh the needs of the many. The Minister has made the opposite argument today, saying that this resource cannot be made available in individual cases because the resource could so effectively be used in other areas. But while there are individual cases, which we have all heard about, and we've heard about another one today, where people who could benefit from these treatments are not receiving them because of that principle that the needs of the many outweigh the rights of the few, then we have a system that has a fundamental weakness. The only party in this Parliament that has brought forward a means by which we can deal with that in the short term is the Conservative Party, and I therefore support the motion that has been brought forward by Murdo Fraser today.
I now call George Adam to follow by Kevin Stewart.
Thank you, Presiding Officer. I know we've got limited time, so I'll try and be brief with this. It's another emotive subject, and I take on board Murdo Fraser's constituent, Gillian Bold, and her family with some of the condition and what they suffered. But I come from a different angle, and I think I'll add to Dennis Robertson's list of potential diseases. My wife, Stacey Adam, as the Cabinet Secretary, actually suffers from multiple sclerosis, and within Scotland we have a higher number of people suffering from this condition than anywhere else per head of population in the world. So the list could go on and on and on with regards to who would think would be the best way to have drugs. I believe a cancer drugs fund actually diverts resources away from other conditions like multiple sclerosis, and I think it is a case of trying to work with as many people as possible and help as many as possible in order to move things forward. The £10 million Cancer Drug Fund, I'm not aware of the Tory manifesto in Paisley. It wasn't required reading during the election, so I don't know where the £10 million is coming for. If Mr Fraser wanted to tell me, I'd be quite happy.
Well, I'm grateful to the member for giving way. If he'd read our fully costed manifesto, he would have seen, amongst other things, we do not think it was right to be giving free prescriptions to people like he and I, who could well afford to pay for them. That money would be better spent on other things.
Mr Adam.
I'm glad I didn't read it, because the people of Paisley had an entirely different idea. They believed they did not want to have a situation with prescriptions where they had to balance whether they paid for their messages or their medication. So I think when it comes to people dealing with long-term conditions, I think we've got a completely different argument in that one. But as the Cabinet Secretary quite rightly said, the early detection is definitely the way forward for a situation like this. Preventative care in some cases of cancer can actually help, because let's not kid ourselves. I think my colleague Alex Johnson mentioned as well was the fact that some of this needs lifestyle change, and we have to deal with alcohol smoking at an early stage so that we can actually help people as we move things forward. So I would just close by saying, Presiding Officer, I think we have to look at Scotland as a whole and the vast number of people who are suffering with long-term conditions. And I believe that the Scottish Government and the Cabinet Secretary have looked at that within the resource that they have.
I now call Kevin Stewart to be followed by Mary Fee.
Thank you, Presiding Officer. I think everyone has said that this is a very emotive debate, and it is. There's probably no one in this chamber or no one watching this debate that has not been touched by cancer in some way, whether that be family or friends or even themselves. Presiding Officer, I'm here in this chamber today having been selected for the Aberdeen Central seat at the last minute because the lady who had been selected was diagnosed with cancer. So everyone has been touched by this. I don't think that the solution, though, is a separate drugs fund, and I think colleagues have touched upon this already, but I think it's worth continuing this, because if you're going to create a separate drugs fund for cancer, what other drugs funds are you going to have to create? That is the key thing for me in this debate, because there are huge amounts of other diseases, some terminal diseases, which some could argue would benefit again from a separate drugs fund. So where does that end? And I think that Alison McInnes, in her speech, summed it up in some regards. And her colleague, Ross Finney, said, well, he's criticised the Tory plans for a cancer drug fund. He said the Conservative plan for a cancer drug fund is unfair. The Scottish Medicines Consortium is the independent body designed to recommend the cost-effectiveness of drugs. Politicians should not be second-guessing the SMC. And I agree with those comments, and I think this has been mentioned from all sides apart from the Tory benches. And I think we should take cognizance of that. I will
concede that while it is not the job of politicians to decide which drugs should be available, it is certainly the job of politicians to ensure that the rights of individuals are protected against a policy which may take resource away from them to benefit other activities.
Kevin Stewart.
Thank you, Presiding Officer. I was listening to the debate yesterday on mental health, where there seemed to be agreement that it was up to clinicians to decide what to prescribe. And I think that where we have a situation at the moment, we have physicians go and submit individual patient requests, and I think that that is the way to do it, and I don't see a problem with that at all. But I don't think that we as politicians should be second-guessing the experts in these fields. Obviously, Mr Johnson agrees. I've given way once, and I only have 4 minutes. I wish, Presiding Officer, that this debate was more about prevention rather than setting up a separate fund. We've heard about the Early Detection Fund, and I certainly welcome the monies that have been put into that, and I'm sure right across the chamber we do. But sometimes we don't deal with the prevention very well. And in this place, we often have the opportunity to meet folks who are involved in various health organisations. And Ken McIntosh from the Labour benches recently, the other week, had Mascot, the Melanoma Action and Support Scotland group here in Parliament, and Mary Fee attended that event as well. Now, in some regards, we could have simple solutions to deal with some of the problems. Melanoma is on the increase, and yet we charge VAT on sunblock and sunscreen.
The member really needs to wind up.
Thank you, Presiding Officer. I think that we should think about that, think about prevention, rather than necessarily having to deal with the cures all of the time. Thank you, Presiding Officer.
Mary Fee, to be followed by Mark MacDonald.
Thank you, Presiding Officer. I welcome the opportunity to speak in such a sensitive but crucial debate. The Scottish Conservatives are very right to bring this issue to the Chamber today, and I support any initiative to improve patients' treatment of cancer, but I do not believe a cancer drugs fund is the answer. A drugs fund would not solve the problem of the drug approval system, but would simply bypass them. The Conservative proposals do not address the root causes of why patients might be denied access to some treatments, a feeling that's shared by Breast Cancer Breakthrough, Myeloma UK and Macmillan Cancer Support. The motion by Murdo Fraser is right to point out the finding of the Rarer Cancers Foundation, but does not address why there are treatments in England that are not north of the border. The drug approval system in both countries are very complex, but what we must do is improve the transparency around the Scottish Medicines Consortium, their decisions and the implementation of their decisions. I would like to back calls by Breast Cancer Breakthrough, Myeloma UK and Macmillan Cancer Support for an investigation into which factors contribute to the situation where drugs are rejected by SMC on the basis of cost and clinical effectiveness, and how we can address these situations. I find it worrying that the Conservatives would pay for the Cancer Drugs Fund by bringing back prescription fees. To me, this is a tax for certain illnesses to pay for others. Any money that would be used in a drugs fund should be used to improve early detection of cancers and reduce the waiting times that patients experience, like the Labour manifesto pledged. It's wrong that someone suspected of having cancer should wait 4 weeks to see a specialist. As much as we need to improve and extend the life of a cancer patient, a drugs fund does not go far enough. More early detection and prevention of cancers are needed, and even the Society and College of Radiographers have criticised the Cancer Drugs Fund in England, the same system that the Scottish Conservatives have based their plans on. According to Audrey Patterson, Director of Professional Policy at the Society and College of Radiographers, it would take only a fraction of the £200 million budget to deliver cutting-edge radiotherapy services across the country, and the impact would be immense. That's an example of how the professionals feel regarding the fund in England, and Ms Patterson is correct to say that more money should be invested in more effective treatment services. I understand some patients may be beyond the stage where radiotherapy would help their cancer, and that's where I feel the heart of this debate must lead to. Should we be providing drugs that improve the life chances of the cancer sufferer or simply extend their life? I would hope that any drug approved by the NHS, SMC or any government would do both. Like I said at the start, this is a very sensitive debate and one where party politics should play no part, but we need more investment in early diagnosis, successful treatment and to rid each health board of a postcode lottery. Thank you, Presiding Officer.
Thank you very much. I now call Mark MacDonald.
Thank you very much, Presiding Officer. Like many in the Chamber and wider society, I have experience of losing a family member to cancer. So I think it's worth noting that none of us in the Chamber are immune to the situations that are faced by people across Scotland on this. However, that being said, we must always try and avoid becoming too emotional during debates on this, and we must be rational as well as emotional when we discuss cancer, in particular cancer treatment. In terms of the Cancer Drug Fund, it would be fair to say that it is not universally acclaimed and has not met with the universal acclaim that one might assume, having listened to the speeches on the Conservative benches. Indeed, a recent article in the Lancet Oncology Commission journal stated that, however, because decisions are regional, it reintroduces the postcode lottery, therefore leading to disparities within England, as the Cabinet Secretary outlined. Indeed, an article in the Daily Telegraph, which Mary Fee referenced, saw that the Society and College of Radiographers had quite clearly stated that it was diverting money away from treatments and from areas such as radiotherapy services. So there is clear evidence that the Cancer Drugs Fund is not all that it is cracked up to be, and therefore I think we should exercise a degree of caution. What I think is entirely appropriate is that we focus our efforts on efforts to try and deal with prevention and preventative spending, which has become a theme in which this government is seeking to drive forward. Early detection is something which this government is extremely keen on, and I am extremely supportive of the government in that, because the earlier that you can detect cancer, the greater the opportunity and the greater the survivability of that cancer. And I think we should be focusing our efforts on early detection, not necessarily diverting money towards treatments for end of life and towards the end of cancer. Now, I fully accept that this is an emotional issue, but we must always weigh up the fact that in many cases, prolonging life does not always increase the quality of that life, and we must always be very careful when we are looking at life-prolonging treatments that the key consideration for any health professional must be the quality of life for the individual, not necessarily the longevity of that individual's life. And in that regard, there's another area where we need to ensure that we have expenditure, and that's at end-of-life and palliative care. And again, this is an area which I would be concerned would potentially be neglected if we were to focus our efforts simply on directing money towards treatment of cancer rather than early detection and also appropriate end-of-life care for those individuals who are no longer responding to treatment or who require to simply be made comfortable towards the end of their life. Indeed, the Lancet journal itself states, today early detection and cancer-specific treatment advances have resulted in increased survival. And that is where I support the government in terms of early detection, because it increases survival of cancer. It is where we should be targeting our efforts. Presiding Officer, I think that the debate is a worthwhile debate to have, but I think that the establishment of a cancer drug fund would, I think, be a distraction. And I think it would be a distraction because we would then face calls from other organisations dealing with terminal conditions to say, well, if cancer drugs are a priority, why not drugs for heart disease? Why not drugs for Alzheimer's? And I think that we must ensure that at all times the health of the nation as in general is the priority for this Parliament. Yes, there will undoubtedly be individual cases that need to be dealt with. There always are. And I think that the appropriate way to deal with them is as individual cases, as highlighted by the Cabinet Secretary. And where there are local difficulties, it is entirely appropriate that those local difficulties should be highlighted to government to see if government can make changes in terms of the mindset at a local level. But to deal with local difficulties on a national basis, I think, is sledgehammer to crack a nut.
Mr MacDonald, could you conclude?
I'll simply conclude by quoting one last thing from the Lancet Oncology Commission Journal, which says, "Prevention is also essential, and this too demands political will, ample funding and a substantial change in mindset." I think this government has demonstrated the political will, demonstrated the funding and the change in mindset required to ensure prevention is the heart of what we do.
I now turn to the closing speeches, and I call on Alison McInnes, who's kindly offered to take less than an allocated time. Thank you.
Thank you very much, Deputy Presiding Officer. I listened carefully to the Cabinet Secretary's response this morning and found it illuminating. The situation is not as clear-cut as the Conservatives have suggested this morning, and her point that comparisons are not always valid, I think was telling. Most of us have acknowledged this morning that a great deal of work has been done here in Scotland since the Petitions Committee inquiry. We know that the SMC is actually quite responsive. The Cabinet Secretary reminded us that the SMC reviews all new drugs, while NICE reviews only a selection. And we know that in such a small country, it's quite easy for it to be more responsive. But I think Jackie Baillie rightly questioned the geographical variations that there are in the approach of area drug committees, and actually questioned whether or not they are putting a brake on the system altogether. And I would support her request to review that. That seems to me a sensible suggestion. I would re-emphasise the need to invest in early detection. Alex Johnson referred to our poorer outcomes compared to the rest of Europe, but I agree with the comments of most other members in the Chamber today relating to the need to focus on early detection. That's really the way to drive down that particular problem. Too many cancers at the moment are only detected as at unplanned admission times. I think really the truth of this debate today, at the heart of the debate, is a question of fairness. I really don't understand why it should be that one particular set of illnesses should be exempted from the process of balancing the clinical effectiveness with the health economics. I don't mean to sound harsh. I do understand the suffering caused by these dreadful illnesses, but Dennis Robertson, amongst many other people, echoed that point, drawing attention to the needs of stroke patients, heart patients, those with MS. I do believe pharmaceutical companies could do much more to bring drugs into the mainstream more quickly. And the value-based pricing approach being developed in Westminster at the moment should open up access to more drugs more quickly by factoring in more considerations. There are questions over how this new scheme would interact with the existing arrangements and with the work of the SMC. So again, I would urge the Scottish Government to work with their colleagues in Westminster to ensure that new proposals serve the needs of Scotland. Thank you.
Thank you very much. I now call Dr Richard Simpson. You have 4 minutes, Dr Simpson.
Thank you, Deputy Presiding Officer. Can I welcome the fact that the Conservative Party have raised what is an important issue. And I think although it could have been emotive, in fact it's been debated in a very sober manner by this Chamber, and I think that's only as it should be. I think that, as the Cabinet Secretary has said, and Jackie Baillie, Mary Fee and Mark MacDonald have all said, and others have alluded to, that early diagnosis and treatment must be our priority, and I think we've agreed that, and the funding is being put in place. We may slightly disagree on how it's being applied, but nevertheless, that is the priority, and that's very important. As in everything, we must start with the needs of the patient, and new medicines for cancer in the pipeline. There are possibly 8 more this year, and many more to come. But there will also be in the pipeline for other conditions. The Scottish Medicines Consortium has really served us extremely well. And as Alison McInnes, Malcolm Chisholm have indicated, it actually has been highly praised and internationally accepted for its speedy work. The industry has also been happy with it in terms of the interactive approach that it's adopted, apart from some problems around orphan and ultra-orphan drugs. But we can't afford ignore the fact that, unlike England, SMP approval does not mean automatic availability. In Scotland, we have the additional hurdle of 14 area drug and therapeutic committees, potentially making different decisions on licensed and approved drugs, and as my colleague Jackie Baillie says, at least in one instance, taking between 1 and 16 months to introduce an approved drug. Now, that variation, I think, is unacceptable, and it's questionable as to whether that is fit for purpose. Why is this relevant? Well, it's relevant because if not approved by the Scottish Medicines Consortium, a medicine then enters what was known as the exceptional needs system. But if the Area Drug and Therapeutic Committee doesn't approve a medicine that's licensed and approved by the SMC, it also enters the system. The approach in England of what is actually a transitional fund to value-based pricing is wrong, and wrong for a number of reasons. First of all, the fund is almost certainly going to be inadequate. The number of drugs in the pipeline will outstrip demand, and they will be faced yet again with the same problems that we're all faced with. Secondly, it's inadequate also because, as many speakers have said, it discriminates between cancer and other conditions. New drugs will be developed for many non-cancer conditions. Will they too be given specific funds? So discrimination, as opposed to some form of clinical rationing, will not be tolerated for long. As George Adam and Kevin Stewart have indicated, discrimination could be a major problem. And England has not eliminated the regional variation. So achieving the sort of equity which Alex Johnson referred to is not actually occurring in England within the Cancer Fund. So we need to look at it. Is there a problem? Yes, there is a problem if Scots are obtaining substantially less cancer drugs than other groups. But the petition which led to the establishment of the issue of Cell 17 in 2010 with the new system of individual patient treatment requests, or IPTR, has only come into effect in April. So I have, in the 30 seconds left, I have a number of questions for the government. Is IPTR in place across all 14 health boards? Is the process transparent to the public and individuals, not just in rejection and acceptance, but in the whole process? Is it fair to the individual patient, their family, and indeed their clinician? Is it uniform and consistent both within individual boards and across Scotland, or do we have yet another postcode lottery? To whom is the system accountable in its community as well as to Parliament? Have the 14 health boards, do they have the capacity to consider the complex issues involved? Is the membership of the panels broadly similar? Is the community represented? Is the cost-sharing mechanism of PASS adequate? So I will conclude by saying that I think there are a lot of questions to be asked about what is a new system, but I hope that these will be answered in an open and transparent way.
Thank you very much. I now call on Nicola Sturgeon. You have 6 minutes, Ms Sturgeon.
Thank you, Presiding Officer. I, like others, think this has been a good debate. I think it's been a calm and rational and high-quality debate. I thought Kevin Stewart very helpfully reminded us, if we needed reminding, that this is not an abstract debate. All of us at some point in our lives will have been or will be in the future touched by cancer, and I think it's always important to keep that in mind. Murdo Fraser, Alex Johnson, although I don't agree with the motion, nevertheless, I thought made good points. Our cancer survival rates are not as good as they should be, not as good as I would want them to be, and I think that's something that we recognise across the chamber. What I would challenge is the proposition that that is entirely down to access to drugs. That, in my view, is significantly down to comorbidities and late diagnosis, and it's that we need to effectively tackle if we are to significantly improve cancer survival rates, and that's the commitment backed by resources that this government has given. Alison McInnes, I thought, made a very good speech and reflected the improvements that have been made, the need to monitor them and ensure that they have the desired effect. She specifically asked if there were any drugs approved as a result of the new SMC modifiers. The quick answer to her question is that so far during 2011 there are 3 cancer medicines for which modifiers could be applied that were approved by the SMC. Jackie Bailey, I think, rightly said, as did others, that we should always look critically at how the system is operating, not just in principle, but in practice. I'm happy to give further consideration to the points about area drug and therapeutic committees. Points were made by Jackie Bailey, Richard Simpson and others about individual patient treatment requests. As I said in an intervention to Jackie Bailey, we have asked all health boards to provide us with information on the number of requests, the number of approvals, the number of appeals, and the drugs and the indications concerned. That, I think, will be important information to inform a judgment about how the system is operating. But members will be interested to know that information made available in January of this year as a result of freedom of information requests showed that over the past 3 years, 92% of these kind of individual patient requests had been approved by boards. Malcolm Chisholm rightly, and others indeed, rightly pointed out, and I want to echo and endorse this point, that the Scottish Medicines Consortium is not just respected in Scotland, it is respected across the UK and worldwide. That doesn't mean we should cast it in stone and never look to improve how it does its work, but it is a respected organisation applying respected methodology. Malcolm Chisholm, I thought, used what is the key word in all of this, which is transparency. That is critical to determining how fairly and equitably the system is working, and I couldn't agree with that more strongly. And it's transparency that we have been seeking and will continue to seek to bring to the whole process. And in response to Malcolm Chisholm, I would be happy to issue the guidance and other information to MSPs, or at least to those who are interested in receiving it. So I think there have been a number of very considered speeches made today. I can't respond to all of the points, but Mark MacDonald, Mary Fee, I thought, made a particularly considered speech, and others who have spoken. For me, there are two key points in this debate. The first, I hope, is a point of agreement more than a point of contention, and that is we should be working continuously to improve access to drugs. For me, that bit of this debate is not in contention, but I believe we should be working to improve access to all drugs, not just some drugs, and in a way that is fair and consistent. And I thought George Adam very powerfully summed up the importance of that. You know, I get letters from cancer patients who passionately believe that a particular drug can benefit them. And these situations are heartbreaking. But I get similar letters from patients with Alzheimer's, with MS, with heart disease, who also believe that a particular drug could have these benefits. So I believe fairness, consistency and equity is so important in this debate. And the second point that is key for me in this debate is that we must tackle cancer in all its ways, in every way at our disposal. You know, a couple of weeks ago I visited the Western General Cancer Centre to see new state-of-the-art radiotherapy equipment. Western General is one of only a handful of cancer sites in the whole of Europe that has this equipment now. It will transform how radiotherapy and surgical procedures are delivered. Likewise, the points that have been made about the need for earlier detection. As I said earlier on, our relatively poorer cancer survival rates are down to the fact that for a variety of reasons, we present later with symptoms and we are diagnosed later, and therefore, no matter how short our waiting times are, often no matter how good our drugs or our other treatment are, the chances of survival are reduced because the disease is too far progressed. So these are the challenges. They are big challenges. I don't underestimate them, and I am absolutely committed to doing everything we need to do. But let's do it comprehensively, let's do it fairly, let's do it consistently. I move, again, Presiding Officer, the amendment in my name.
Thank you very much. I now call on Mary Scanlon to wind up the debate. You have 8 minutes, Ms Scanlon.
Thank you. I very much welcome this debate, but I think more than welcoming the debate, I would like to put on record that I very much welcome and acknowledge the tone of this debate from all MSPs who contributed. And we also note the commitment by the Health Secretary to look further into many issues raised today. We may disagree on many things, but I think many contributors have raised issues of concern relating to transparency, etc. But there is no doubt that huge progress has been made in cancer treatments and recovery rates. Cancer is now generally discussed around treatment, hair falling out, the Maggie Centre and getting back to work. No longer do we say, how long has he got? But whilst acknowledging the progress in so many of the common cancers, there is undoubtedly still much more to be done for cancers such as pancreatic, melanoma, as Kevin Stewart raised, and I was at the dinner also, and cancer of the esophagus, to name but 3. As Murdo Fraser said, for 14 treatment requests per million population in Scotland, 14 are approved under the individual patient treatment scheme, and that compares to 48 approved in England under the current system. So I commend the work done by the Rarer Cancers Foundation in highlighting the needs of people with more exceptional cancers. It was always going to be the case that drugs would be more expensive given the lack of economies of scale in production and the smaller patient group for purchasing. The Rarer Cancers Foundation state in their briefing for today that they have been contacted by patients in Scotland who have not been able to access the treatments that their clinicians wish to prescribe that are available to patients living in England through the Cancer Drugs Fund. It is therefore right and proper that we have this debate to flesh out the differences between the two jurisdictions and to ensure that patients in Scotland are treated equally and fairly. I should say at this point, as Cabinet Secretary I think has said, that the United Kingdom falls behind most of the European countries, both in the number of cancer drugs prescribed and the amount of money spent on these drugs. That is according to the Cancer Research UK today. So I don't think we should just compare ourselves to England. But as others have said, even if a drug is approved by the Scottish Medicines Consortium, it may not, in some cases, be routinely available in NHS Scotland. We also, as Richard Simpson has said, have the local drugs and therapeutic committees, whose opinions can vary between the 14 health boards. I thought Alison McInnes raised a very good point in the Lib Dem motion, which I trust that the Health Secretary will address. And I quote from the motion that nearly a third of NHS boards have no written policy governing exceptional case applications in place, and the NHS boards use variable criteria to assess exceptional case applications. So I am pleased that the Health Secretary will look further into this. The analysis carried out by the Rarer Cancers Foundation in the Scottish Exception and Exceptional Scotland showed a number of treatments that had been applied to via exceptional case requests in Scotland, which were in fact SMC approved. Individual patient treatment requests was raised by some speakers today, and one or two speakers mentioned that this is subject to serious and considerable delay in time, and that is often time that a cancer patient doesn't have. There are other issues which have been highlighted in this debate relating to the need for greater transparency and clearer communications on the rationale for SMC decisions, so that patients and clinicians fully understand why certain drugs are not approved for use on the NHS in Scotland, an issue highlighted by Malcolm Chisholm, Richard Simpson and Mary Fee. But we now have a nation of patients who are much better informed through online information. They have a clear understanding of why drugs recommended in one country are not recommended in another. And when a drug has been approved by the SMC but refused by the local Health Board Drugs and Therapeutics Committee, it is natural that patients feel denied certain drugs. And it's also obvious in these difficult financial times that this can potentially lead to postcode prescribing across Scotland. And for all these reasons, the Conservatives support a £10 million National Cancer Drugs Fund for Scotland. I understand that the Cancer Drugs Fund in England has already helped over 5,000 patients. And Mark MacDonald, I think, made a very good point about the quality of life. That is precisely what these cancer drugs bring. And I would just remind the Chamber that Mike Gray from Buckie, who brought forward the petition on cetuximab, Mike Gray worked until 3 weeks before his death. And on the subject of value-based pricing, I note that the Scottish Government is working with the UK Government to ensure that this scheme, due to be implemented in 2014, will meet the needs of patients in Scotland. So I would like to thank everyone who contributed to this debate. It is right to continue to highlight the progress that we've made. I think that much more can be done, much more is being done in diagnosing and treating cancer, and it is right that we continue to examine how we can improve treatments for all people with cancer in Scotland. So I support the motion in Murdo Fraser's name.
Thank you very much. That concludes the debate on cancer drugs and their availability in Scotland.